The blood pressure pill. Your provider persists in giving, and why it's actually harming you. For many individuals, a prescription for a beta blocker for blood pressure might feel like a straightforward solution, a reliable part of their daily routine for years. Yet, a quiet but profound question is increasingly being raised by medical professionals. What if this very medication, taken so faithfully, is contributing to feelings of persistent tiredness, unexpected weight gain, or a general slowing down that was mistakenly attributed to the natural process of aging? This isn't a minor consideration, it's a vital one, impacting millions of lives and challenging long-held assumptions within healthcare. Currently, over 40 million Americans aged 60 and above are prescribed beta blockers, a number that underscores the widespread use of these medications. However, a growing chorus of cardiac specialists and researchers are thoughtfully questioning whether such widespread application is always appropriate for every individual, especially in light of evolving medical understanding. This crucial conversation often gets overlooked in the brief moments of a standard doctor's appointment, where time constraints limit comprehensive discussion. Beta blockers have a long and impactful history, tracing their origins back over 6 decades. The very first compound, propranolol, emerged in 1964, marking a truly revolutionary moment in cardiovascular medicine. Scientists had discovered a groundbreaking mechanism. By effectively blocking specific receptors within the heart, these drugs could significantly slow the heart rate, thereby reducing the heart's overall workload and lessening the force of each individual beat. This action directly translated into a significant reduction in blood pressure, offering a powerful new tool for managing hypertension. The medical community at the time was understandably enthusiastic about this discovery, and for good reason. Throughout the 1970s and 1980s, beta blockers rapidly ascended to become the primary, almost automatic treatment for high blood pressure across the entire Western world. A patient presenting with hypertension would very frequently receive a prescription for a beta blocker as a first-line therapy. The perception was that these drugs were safe, thoroughly proven, and their use was consistently reinforced through medical education year after year. However, medicine is a dynamic field, constantly evolving as new research emerges and understanding deepens. A considerable amount has been learned since 1964. With scientific inquiry venturing into surprising new directions. Unfortunately, the cutting-edge insights and updated understanding don't always filter down into every doctor's office or lead to immediate changes in every patient's long-standing prescription. It is this disparity, this critical gap between the latest evidence and current practice, that warrants our careful attention and discussion. To grasp the essence of how these drugs function, consider a simplified explanation. Your heart is equipped with specialized receptors, akin to tiny switches embedded on its surface. Under conditions of stress or physical exertion, your body releases adrenaline, a potent chemical messenger. Adrenaline acts by flipping these switches, prompting your heart to accelerate its beating rapidly in response to demand. Beta blockers, in essence, are designed to intercept and block these switches. By doing so, they prevent adrenaline from fully engaging these receptors, resulting in a slower heart rate, reduced pumping force, and consequently lower blood pressure. On the surface, this mechanism appears perfectly logical and beneficial. Indeed, for certain specific medical conditions, this approach is undeniably the correct and most effective one. We will delve into those particular scenarios shortly. However, a critical distinction arises when considering the aging cardiovascular system. By the time an individual reaches 60, 65, or 70 years of age, their heart and circulatory system operate quite differently compared to their younger self at 40. For instance, a person's resting heart rate naturally tends to be lower with age, and their blood vessels become inherently less flexible and elastic. Furthermore, the kidneys, which play a crucial role in metabolizing and eliminating medications from the body, typically process drugs much more slowly in older adults. What might be an ideal and well-tolerated treatment for a 45-year-old body can therefore elicit a very different and sometimes even harmful response in a 68-year-old. This age-related difference in physiological response is not merely a nuance, it is a factor of enormous significance in personalized medicine. Understanding this fundamental shift in how the body handles medications as it ages is paramount, as it directly influences the appropriateness and safety of long-term drug regimens. This distinction becomes profoundly important when we look at how the understanding of beta blockers has evolved over time. For many years, the body of evidence supporting the use of beta blockers for hypertension appeared unequivocally robust and dependable. Both doctors and patients placed immense trust in these medications, and fundamental questions about their long-term routine application for uncomplicated high blood pressure were rarely asked. This prevailing consensus, however, began to shift dramatically with the advent of a landmark clinical study that fundamentally reshaped medical perspectives. That pivotal study was the Anglo-Scandinavian Cardiac Outcomes Trial, widely known as the ASCOT trial, which published its groundbreaking findings in 2005. This comprehensive trial undertook a direct comparison of beta blockers against a newer class of blood pressure medications, specifically calcium channel blockers, involving a substantial cohort of patients diagnosed with hypertension. The outcomes of the ASCOT trial were so compelling, so strikingly clear in their implications, that the study was actually halted prematurely before its scheduled completion date. The ethical considerations driving this early termination were profound. Patients randomized to the newer calcium channel blocker group demonstrated significantly superior health outcomes, experiencing markedly fewer strokes, a reduced incidence of heart attacks, and notably a lower risk of developing type 2 diabetes. In stark contrast, the beta blocker group did not merely perform less favorably. The difference in outcomes was so substantial that continuing the comparative arm was deemed ethically indefensible by the researchers. The results clearly indicated a disadvantage that could no longer be ignored. In the aftermath of the ASCOT trial's publication, major medical organizations globally initiated a quiet but significant process of updating their clinical guidelines. The speed of these revisions varied, but the direction was clear. For example, the British Hypertension Society explicitly removed beta blockers from the list of first-line treatment options for individuals with uncomplicated high blood pressure. This represented a substantial paradigm shift in treatment recommendations. Other European guidelines soon followed suit, adopting a more cautious stance. Similarly, American guidelines increasingly advised against the routine, automatic use of beta blockers for hypertension without complicating factors. Yet here lies a critical and genuinely concerning gap for many practicing physicians. While guidelines are updated and published in medical journals and textbooks, these changes do not automatically translate into immediate adjustments for every patient's existing prescription. Often, a long-standing beta blocker prescription for blood pressure simply gets renewed automatically within the healthcare system without a dedicated review. Millions of patients who began taking these medications 5, 10, or even 15 years ago continue their regimen without anyone actively questioning its continued appropriateness in light of updated evidence. This situation is not a criticism of individual doctors, who are often operating under immense time pressure within complex healthcare systems. It is an honest reflection of the systemic realities of modern medical practice. However, this reality means that the responsibility sometimes falls on the patient to initiate this crucial conversation with their healthcare provider, and that is precisely the purpose of this discussion today, to empower you with the knowledge needed to engage in such an important dialogue. A consistent observation among patients over 60 who seek medical advice after years on beta blockers for blood pressure is a shared sentiment. Almost universally, they express a similar thought. I just assumed I was getting old. I thought feeling this way was a normal part of aging. The fatigue they describe is profoundly real, and its physiological basis is directly linked to the medication. Beta blockers, by their very design, slow your heart rate. This is their precise mechanism of action. However, a heart that beats slower pumps less blood volume per minute, which directly translates to a reduced delivery of oxygen to your working muscles throughout the body. Consequently, when you engage in everyday physical activities, such as climbing a flight of stairs, walking to the mailbox, or carrying groceries from your car, your body simply cannot respond with the same vigor and efficiency it once did. Your heart is, in effect, physically constrained from accelerating to meet the increased demands of your muscles. It's an experience akin to attempting to drive a car uphill with the engine electronically capped at only half its normal power output. You press the accelerator, but the expected surge of power simply isn't there. This leads to a pervasive sense of exhaustion and an inability to perform tasks that once felt routine. What makes this particular side effect especially insidious and challenging to recognize is its subtle nature and the subsequent behavioral changes it elicits. When older adults experience persistent exhaustion during physical activity, their natural inclination is often to reduce or cease those activities altogether. They find themselves sitting more, moving less, and gradually abandoning once enjoyed walks or hobbies. This reduction in physical activity, paradoxically, is one of the most significant accelerators of the aging process and a primary driver of cardiovascular decline. In essence, a medication initially prescribed to safeguard the heart may, over time, inadvertently trigger a slow chain reaction that ultimately compromises its health and overall vitality. There is a precise clinical term that describes this phenomenon: exercise intolerance. Numerous studies consistently demonstrate that exercise intolerance is significantly more prevalent in older patients who are taking beta blockers. It is a tangible and measurable consequence that profoundly impacts quality of life. Consider for a moment if you are over 60 and currently taking a beta blocker for blood pressure such as metoprolol, atenolol, or bisoprolol. Reflect carefully on the period when you first began the medication. Did your energy levels noticeably shift? Did you find yourself slowing down in your daily routines? And perhaps most importantly, did you quietly accept these changes as an inevitable, natural aspect of getting older? If this resonates with your experience, rest assured, you are far from alone. Thousands of people each year make this very same assumption, attributing medication-induced symptoms to the aging process. Yet, the answer to this personal reflection carries more weight and significance than you might initially realize, as it could point to an avoidable contributor to your current state of health. Beyond the widespread issue of fatigue and exercise intolerance, there is another significant side effect associated with beta blockers that regrettably receives insufficient attention in routine conversations between healthcare providers and patients: their measurable association with an increased risk of developing type 2 diabetes. This is particularly true for older generation beta blockers, such as atenolol. The extent of this increased risk is not negligible. Studies indicate an approximate 22% higher risk compared to patients who are prescribed alternative medications for blood pressure control. A 22% increase is far from trivial. It translates to nearly 1 in 4 additional patients potentially developing a serious lifelong chronic disease that they might otherwise have avoided. This is a disease known to damage the kidneys, impair vision, affect peripheral nerves, and significantly compromise the cardiovascular system, all stemming from a medication initially taken specifically to protect the cardiovascular system itself. The underlying physiological mechanisms driving this connection are actually quite well understood within medical science. Beta blockers can interfere with the intricate processes governing how your pancreas releases insulin in response to fluctuating blood sugar levels. Simultaneously, they tend to reduce insulin sensitivity within muscle tissue, making it harder for cells to absorb glucose from the bloodstream. Compounding these effects, beta blockers can also lead to an elevation in triglyceride levels while concurrently lowering levels of HDL cholesterol, often referred to as good or protective cholesterol. The cumulative impact of these metabolic changes is a profile that subtly but persistently pushes the body in an unfavorable metabolic direction year after year, gradually increasing the risk of insulin resistance and ultimately type 2 diabetes. Furthermore, there is a frequently overlooked issue of weight gain that many individuals fail to connect with their beta blocker medication. A significant number of patients on long-term beta blocker therapy report gaining weight, often without any substantial alterations to their dietary habits or calorie intake. The medication itself can modestly slow down the body's resting metabolic rate, meaning the body burns fewer calories at rest. When this metabolic slowdown is combined with the reduced physical activity that often results from drug-induced fatigue, the pounds can accumulate quietly and steadily over months and even years. Patients often internalize this weight gain, blaming themselves entirely and concluding they are simply eating too much or moving too little. In many of these cases, however, the beta blocker is a significant, if unrecognized, contributor to the weight accumulation. It is important to emphasize that not everyone on a beta blocker will inevitably develop diabetes or gain weight. Individual responses to medications vary widely. However, if an individual is already predisposed, perhaps showing borderline fasting glucose levels, or if their doctor has ever raised the term pre-diabetes, then this is a conversation worth prioritizing. The medication in their daily pill organizer could potentially be accelerating an undesirable metabolic trajectory. Another critical area that receives far too little attention, even within specialized cardiology circles, is the direct connection between beta blocker use and the risk of falls in older adults. The underappreciation of this particular risk is deeply concerning given its potentially severe consequences. The physiological sequence of events is quite clear and clinically recognized. Consider a common scenario. An individual has been resting, perhaps lying down or sitting quietly while reading, watching television, or sleeping. Then they suddenly stand up, perhaps to answer a phone call or get up in the middle of the night to use the bathroom. In a healthy, unmedicated body, a rapid, almost instantaneous compensatory mechanism kicks in. The heart rate subtly increases, blood vessels throughout the body constrict slightly, ensuring that blood pressure remains perfectly stable as the person transitions to an upright position. However, when an individual is on a beta blocker, this crucial rapid compensatory adjustment is blunted or impaired. The heart is physically prevented from responding quickly enough to the sudden change in position and gravitational demands. As a result, blood pressure can drop sharply and transiently for a few critical seconds. During these moments, the person may experience dizziness, lightheadedness, or a sudden feeling of unsteadiness on their feet. This experience has a specific medical name: orthostatic hypotension. In adults over the age of 65, orthostatic hypotension is one of the most common and dangerous triggers for serious falls. A hip fracture, for example, in someone over 65, is by no means a minor inconvenience. This cannot be stressed enough. Studies consistently show that up to 30% of older adults who suffer a hip fracture will, tragically, die within 12 months of the injury. This mortality is not typically from the fracture itself, but rather from the devastating cascade of complications that often follow: prolonged immobility, infections like pneumonia, the formation of blood clots, and other systemic issues that can initiate a rapid decline in overall health. This tragic sequence can begin with something as seemingly innocuous as one wrong step following a moment of dizziness. What is particularly alarming is that most patients who experience orthostatic hypotension don't even recognize it as a significant medical problem. They might simply feel a little dizzy sometimes when I stand up. They instinctively grab onto a nearby counter, sit back down for a moment, and the feeling passes quickly. Because it seems minor and resolves on its own, they often never mention it to their physician, assuming it's not a symptom worth reporting. If this description sounds familiar to you or to someone you deeply care about, it is imperative to note this specific experience down and bring it to your next medical appointment. That fleeting moment of dizziness upon standing should never be dismissed. It is a genuine clinical finding that warrants a proper clinical evaluation and response. It could be directly, not just indirectly, linked to the medication in your daily pill organizer. It is absolutely crucial to be direct and unequivocally clear about a very important point, as it would be profoundly irresponsible for anyone viewing this information to walk away with the wrong message. Beta blockers are not inherently bad drugs. On the contrary, in the appropriate patient for the correct underlying medical condition, they are undeniably life-saving medications. Many healthcare professionals, myself included, prescribe them regularly within our practices. Indeed, there are very specific clinical situations where discontinuing a beta blocker would not only be ill-advised, but genuinely dangerous, potentially leading to severe adverse outcomes. Firstly, if an individual has been diagnosed with coronary artery disease, which involves partially narrowed arteries supplying blood to the heart muscle, beta blockers offer a meaningful and proven benefit. They significantly reduce the workload on the heart, thereby lowering the risk of a heart attack by decreasing how hard the heart has to labor each day. This specific protective effect is robustly supported by extensive medical evidence. Secondly, for individuals who have already survived a heart attack, beta blockers are considered a fundamental cornerstone of both their immediate recovery and long-term protection. These medications play a critical role in safeguarding the vulnerable heart muscle. Beta blockers are no longer the consistently recommended first choice for straightforward, uncomplicated high blood pressure in an individual over 60. What are the current evidence-based alternatives? Modern research and updated guidelines point very strongly toward two primary classes of medications as preferred initial therapies. The first major class includes calcium channel blockers, with amlodipine being one of the most widely prescribed examples. These medications operate by directly relaxing the muscular walls of your blood vessels, which physically eases the flow of blood through them and reduces resistance. Crucially, they achieve this blood pressure lowering effect without interfering with the heart's natural ability to speed up during physical activity, and they do not negatively impact blood sugar levels. Studies, most notably the ASCOT trial, have demonstrated that these drugs are more effective than beta blockers at reducing the risk of stroke and heart attack for patients with uncomplicated hypertension. For individuals who do not have underlying coronary artery disease, heart failure, or existing arrhythmias, the difference in clinical outcomes offered by calcium channel blockers is genuinely significant. The second important class encompasses ACE inhibitors and angiotensin receptor blockers, ARBs. Common examples in this group include lisinopril, ramipril, losartan, and candesartan. These medications exert their effects by blocking a specific hormonal system within your body known as the renin-angiotensin system, which is one of the primary physiological drivers of elevated blood pressure. A notable benefit of these drugs is their meaningful protective effects specifically for the kidneys, an aspect that becomes increasingly important as we age and kidney function naturally tends to decline. Furthermore, ACE inhibitors and ARBs typically carry what is referred to as a cleaner metabolic profile. This means they generally do not promote insulin resistance, do not tend to raise triglyceride levels, and are not associated with weight gain, thus avoiding some of the metabolic drawbacks seen with other blood pressure medications. It is absolutely vital to emphasize with utmost clarity that this information does not constitute personal medical advice. I am not your individual physician, nor am I instructing you to make any changes to your medication regimen today. Your unique medical history, specific diagnostic test results, and any coexisting health conditions are all critical factors that must be thoroughly discussed in a personalized conversation with a qualified healthcare provider who possesses a complete understanding of your individual case. However, if you are an individual over 60 years of age, currently taking a beta blocker purely for the management of high blood pressure and have no documented history of a heart attack, heart failure, or an arrhythmia, then it is entirely and completely reasonable, indeed advisable, to schedule a dedicated appointment with your doctor. During this consultation, you should directly inquire, given my current health status and the most up-to-date evidence-based guidelines, is this medication still the optimal choice for me at this time? Asking such a question is not being confrontational. It is the hallmark of an informed and engaged patient taking an active role in their own healthcare. Any physician who is truly dedicated to their profession and current in their knowledge will genuinely welcome and appreciate this type of thoughtful, proactive inquiry. They understand that patient engagement is a cornerstone of effective medicine. Now, and I genuinely cannot stress this next point enough, I must convey a critically important warning before we proceed further. Under no circumstances should you ever stop taking your beta blocker medication on your own. This applies not tomorrow morning, not immediately after finishing this discussion, and certainly not based on anything you might read online. Please understand that your body has undergone a significant physical adaptation to the continuous presence of this medication over many months or even years of consistent use. This physiological adaptation is very real and profoundly important. Your heart, your blood vessels, and your entire nervous system have all meticulously adjusted and recalibrated their functioning around the constant influence of this drug within your system. When you abruptly remove it, there is a well-documented and potentially dangerous rebound effect. Your adrenaline receptors, which have been blocked and consequently hypersensitized for so long, can suddenly become intensely responsive and hyperreactive. This sudden surge in sensitivity can cause your heart rate to spike dangerously high and your blood pressure to surge to very elevated levels with extreme rapidity. In some patients, particularly those who may have undiagnosed underlying coronary artery disease, this sudden rebound can precipitate a serious and life-threatening cardiac event. This is not a theoretical risk that is being mentioned merely as a precaution. It is a thoroughly documented phenomenon within the medical literature, known to occur and often with rapid onset. The correct and safe method for discontinuing a beta blocker, should that be the carefully considered decision reached collaboratively by you and your doctor, is a gradual process. The dosage must be incrementally reduced in measured steps over a period of several weeks. Throughout this entire tapering process, both your blood pressure and heart rate must be meticulously monitored to ensure stability. In most cases, a replacement blood pressure medication is actually initiated either before or during the taper, ensuring that your blood pressure remains consistently under control throughout the transition. This is unequivocally a medical process that demands professional physician involvement and an explicit, well-structured plan. When executed properly and under medical supervision, it can absolutely be done very safely. Therefore, please take all the valuable information you have gained today and channel it into a structured, informed conversation with your healthcare provider. Do not, under any circumstances, make unilateral decisions about your medications at home in isolation. As a medical professional, sometimes, on the drive home after a long day, a profound thought often occupies my mind. There are an estimated 40 million Americans over the age of 60 currently taking beta blockers. This number is almost impossible to fully comprehend in its vastness. A significant proportion of these individuals are receiving these drugs solely for uncomplicated hypertension. meaning they have no documented history of heart disease, heart failure, or arrhythmias. They simply have elevated blood pressure and a prescription that was written years ago, which has since been automatically renewed within the system without critical review to assess its ongoing appropriateness. How many of these 40 million people are currently feeling exhausted, genuinely tired, and convinced with absolute certainty that their fatigue is simply an unavoidable consequence of their age? How many have quietly ceased taking their evening walks because the stairs have become too challenging, or have abandoned activities they once thoroughly enjoyed, attributing their diminished capacity to the passage of time rather than a medication? How many are sitting today with fasting glucose numbers that are slowly but steadily climbing, completely unaware that their daily medication could be actively exacerbating this metabolic trend? And how many have experienced that momentary dizziness, grabbing the countertop in the dark of night, steadying themselves for a moment, and then returning to sleep without ever mentioning it to anyone, simply because it felt too minor to report? These are the quiet, invisible struggles that truly motivate me as a physician. It's not always the dramatic emergency cases or the intricacies of the operating table that resonate most deeply. Rather, it's the slow, unseen erosion of health and quality of life happening silently in people who are diligently doing everything right, faithfully taking their medication every morning, meticulously following instructions, striving to be model patients, and yet, despite their best efforts, are slowly losing ground, their well-being subtly undermined by an outdated prescription. Here is the single most powerful and practical action you can take after absorbing the information presented today. On a piece of paper, write down this exact question. I have been taking a beta blocker for blood pressure for X years. Given my current health conditions and the most up-to-date evidence-based guidelines, is this still the best medication for me? Presenting that one specific question at your next medical appointment, even handing it directly to your doctor if it helps initiate the discussion, could very well be the single most important health action you undertake this entire year. Medicine is not a static field, it is constantly evolving. The most conscientious and skilled physicians continually update their thinking and practices as new evidence emerges and understanding evolves, and the most empowered and effective patients actively assist them in this process by engaging thoughtfully and advocating for their own well-being. Take care of your heart. Being a well-informed patient is not about being difficult. It is about being your own most vital advocate in your health journey. Always remember to consult your physician before making any changes to your medication regimen.